So it's important for us to understand which case we are dealing with, how to approach that case, what investigations we should advise, and when is the right time to start the DMARDs or not the DMARDs. So I've put together a few cases from my OPD itself, which we see normally see, and some of them which we have made mistakes so that nobody else makes mistakes. So we go forward with those cases. So now what does arthritis means? Arthritis is a very vaguely used term. It can mean guttia, it can mean a lot of things in different languages. It basically means joint inflammation. So when we say arthritis, it's basically the five cardinal signs which we have been taught in our MBBS. That is your pain, erythema, tenderness, restriction of movement, and swelling. So, but arthritis just does not mean that it is happening in the joint. That is very important, which we should understand. That's why we do the blood test. That is the rheumatoid factor, anti-CCP, other antibodies, to be sure, yes, that is it's going on in the blood or not. So arthritis means something is wrong. Just like a case of fever, if you say once you get a case of fever who has been going on for 10 days, 14 days, you tend to look at other causes. So if it's an infection, if it's an autoimmune problem causing the fever, or if it's a malignancy causing the fever, so you tend to work up the patient according to that. The similar thing goes with the arthritis as well. Whenever you see a case of arthritis, don't just start them on DMARDs or start them on steroids or NSAIDs. Make sure what you have clear thoughts in your mind that what is the disease, how I'm going to treat the disease, play a systematic plan for that, and then only you start the treatment. It's not an urgency, never in arthritis, unless we will come across a few cases where I will tell you which are the urgent conditions. But most 90% of the cases are more of that you can wait, take your time, form a correct diagnosis. Why is it important? Because you know then how much you have to achieve the endpoint. Otherwise, we start the treatment and after a few times we are lost again, where we have to stop the treatment, where we have to change the DMARDs or not. And that is when we lose the patient because they start losing confidence in us. So that's why arthritis, if I'll think in your mind, yes, you have to rule out the other causes and then only approach a case of arthritis. So now what is the most important thing when a patient of arthritis, joint pains comes to you is lies in your history. History, we have obviously been taught a lot in MBBS that you should give importance to it. In our examinations, also, history formed a part. But as we get into the practice, we start getting busy practitioners, there's a lot of OPD line. So you tend to skip the history part a lot, which is the very wrong thing, which I have to be. Do not forget the basics, is basically what they say. That's why a pediatrician just diagnoses most of the cases just based on the child's history, mother's history itself. That's why they don't tend to do too many investigations for a lot of people, children. So history is the key in rheumatology case. It will give you an idea whether this is an acute problem, whether this is a chronic problem, whether it is just a localized to the joints, or whether it is a systemic problem. So do spend 10 minutes with the patient, not even 10. You may just, once you go through that format, 7 to 8 minutes at least just for the patient, and you will be able to narrow down your diagnosis. So do take a good detailed history before you proceed for any lab test with the patients. So that's what we have been taught through. History forms important. Whenever we are given references in the ward as well, we always approach the patient, take a stop there, take a detailed history that why it has been going. We have this is a common practice. Even now in my ICUs, I see they have been managing the patients, but nobody is aware of the history of at least 6 months back because they would just look at the acute problem. But the acute problem could be a symbol of something underlying chronic, which we have missed altogether if we don't take the proper history. So do history form 70%. It will help you remove the half the unnecessary labs which we do. And the patient will also be more that you will be spending more time with them. And they get that helps you to build their confidence as well. Examination forms the next 20%, which is equally important. With all this coronavirus coming in, a lot of people started taking the consultations on the telemedicine, and this 20% was totally lost through and through. So they don't, and patients do not want to understand. They want to keep doing it at the discomforts of their home. But what they are missing here is that if once you examine, you are able to narrow down the diagnosis even further. For a simple, a patient may complain of a wrist pain. Without examining, you can't be sure it is an arthritis or is it some decurrent tenosynovitis going on or it is some neuropathy going on. So that is something which we need to make them understand that at least you have to visit the clinic for the first time. Once we have found the diagnosis, then you go with the teleconsults. So examination of each joints and the systemic. Don't forget the systemic meanings respiratory, cardiovascular, abdomen, and a brief general examination looking for lymph nodes should be included. Trust me, it just takes more to 3 to 4 minutes only. Even in this COVID times, we did examine the patients, all the patients who come to the clinic, and it never took us more than 3 to 4 minutes. So it was never too much of a hassle that you have to rush through it to get to the diagnosis. And lab only forms 10%, so that is very thing which you need to understand. And as we proceed with the few cases, you will understand, because labs, if you don't have a good clinical history, you don't have a clinical examination, and you just advise labs, a lot of times you will unnecessarily overtreat the patients. For example, a long patient may have a rheumatoid factor positive. He may have a rheumatoid factor of 45 with a cutoff of 12. Or he may have an anti-CCP which is positive, which is supposed to be more specific for arthritis. His anti-CCP may be around hovering around 50, 60. But he has no history. He has just been advised by some randomly by some physician because he had some family history of arthritis, and examination wise you find there is no synovitis. So will you still treat the patient or not? So that's why lab has a lot of falsies. A lot of times you will have these false lab parameters which you tend to start treatment for. But if the patient doesn't develop symptoms, the clinical examination are all clear, then you don't need to treat the patients. So don't focus too much of your diagnosis on labs. Focus more on the 90% of history and examinations. So before we proceed further, a case of joint pains. So it is always important to distinguish right there. Is it an articular that is within the joint, or is it a non-articular pain? Now, in your OPD practice, you will see more of the non-articular coming than the articular ones. This is a very common thing. That's what we call as a soft tissue rheumatism, or the sites are basically the non-articular ones. So these is a simple joint involvement, and these are all the sites of the non-articular. That is your muscles, your